And here we talk about the types of incontinence, and this just bewilders patients also because people only know they're wet. They don't know the difference between stress incontinence, urge incontinence, functional incontinence, neurogenic incontinence, all the different things that we deal with on the medical side. They just know they're wet and they don't want to be wet anymore and they want to be dry. This little band right here is the sphincteric muscle. It's a relatively thin muscle that sits right below the prostate, and it's the pucker muscle. If you want to tighten up down below, that's the muscle from the pelvic floor that will tighten up and squeeze the urethra. Men, in addition to having that muscle to control for continence, the prostate also is a contributing factor for urinary control. And when the prostate's removed, we only have the sphincter. What we currently see is about 75% of people will have complete control of their bladder within 3 months after their prostate surgery. About 10%, 8 to 10% or so of patients will have persistent incontinence beyond 6 months. And it's usually due to this sphincteric muscle just not being strong enough after the prostate's been removed. The surgical options are 3. We've got 2 different types of slings, an advanced sling and an advanced sling. And we also have the urinary sphincter, the artificial urinary sphincter. If you get the anatomy correct, we're looking up from a patient who's laying on his back. This is his bony pelvis. We have the scrotum and the penis anteriorly. The anus and rectum are back here, and this is an area we call the perineum. And this sling fits in in the perineum, underneath the urethra, and is used to compress the urethra. The way that we get it to put some pressure on the urethra is to strap it in rather tight, and we anchor it. These little dots here are bone anchors into the bony pelvis, placed on one side, stretched across, and then anchored in the other side as well in order to compress the urethra. This device is very effective. We will have 85 to 90% of the patients satisfied with the result, with about 70% of patients being dry, and another 20% getting down to wearing 1 pad per day or less, depending on their physical activity. This is the advanced sling, and this came out about 3 or 4 years ago. We'd had the other one on the market for several years, and this was developed primarily to remove the need for those bone anchors. The surgical dissection is similar. This is again looking at the pelvis. Penis and scrotum are up in front, anus and rectum in the back, a small incision between, and the sling is laid in against the urethra. And instead of anchoring it to the bone, this was designed to have long tails on it that are self-retaining, and it passes through this little window in the pelvis called the obturator foramen, where we pass that sling out through there in order for it to self-anchor into the tissue. No need for sewing, no need for bone anchors. The gold standard for the treatment of urinary incontinence is the artificial urinary sphincter. The device is now down to a single cuff. We can add a second cuff, a very small and manageable pump that's in the scrotum, and a reservoir that goes up behind the pubic bone. The way this works is through an incision in either the perineum, that space between the scrotum and the anus, or sometimes we can do it with an incision in the scrotum, is to implant this cuff around the urethra. Its tubing connects to the pump that's in the scrotum, and the reservoir is up here in the pelvic area behind the pubic bone. The way this actually works is that the pump is pressurized. So the resting state for this is for the pump to be pushing fluid the reservoir to be pushing fluid through the pump into the cuff, and it squeezes the urethra and holds the urine in. The urine is in blue. What you have to do each time you urinate is to pump this device in your scrotum 2 or 3 times. It moves the fluid from the cuff through the pump back into the reservoir, allows you to urinate, and then you have to wait about 2 or 3 minutes to allow this process to reverse itself. And we see the reservoir with its pressure in it will take the fluid and push it back through the pump, back into the cuff, and squeeze the urethra, and again, you're able to retain your urine. The results with this are really very good. Again, we'll see 80 to 85% of the patients dry or satisfactorily improved with this. Our dry rate with this is higher than it is with the slings. About 80% of the patients we can get dry using the artificial urinary sphincter. The other advantage is you are able to control your urination, but it has to be with the pump. The disadvantage with it is that it is multi-component. There are a lot of pieces to it. It, you do have to manipulate the pump each time you urinate. With the slings, you don't have to do that. You just walk up and you go. You don't have the slow stream that can occur with the sling, because this is really not obstructed once the cuff is deflated, and really works quite well.